It's my honor to introduce to you all Dr. Thomason. Dr. Thomason is board certified in anatomic pathology, clinical pathology, and hematology. He earned his medical degree with highest honors from the University of Tennessee School of Medicine in Memphis, and he completed his residency in anatomic and clinical pathology at Wilford Hall Medical Center at Lackland Air Force Base in Texas, and a hematopathology fellowship directed by Dr. Peter Banks at the University of Texas Health Science Center in San Antonio. Dr. Thomason previously served as Director of Hematopathology for Blount Memorial Hospital and Kessler Air Force Base Medical Center. He also served as Medical Director for Molecular Pathology Laboratory in Maryville, Tennessee. Dr. Thomason has published several articles in the American Journal of Clinical Pathology. He is a member of the American Society for Clinical Pathology, the American Society of Hematology, and the International Society for Advancement of Cytometry. Dr. Thomason's topic today is Beyond the CBC Report, Extended Laboratory Testing in the Evaluation of Leukemia and Lymphoma. So without further ado, please welcome Dr. Thomason.
Thank you. Thank you, Kim. So as she mentioned, I currently practice as a hematopathologist in Brentwood, Tennessee at Integrated Oncology. Integrated Oncology is a subsidiary of Laboratory Corporation of America. And in our practice, we do a lot of study of neoplastic hematopathology. And so today I wanted to discuss some of the testing that takes place beyond the CBC, the complete blood count, and the diagnosis of hematologic conditions such as leukemia, lymphoma. It's a disclosure. So my goals for this discussion will be to understand that the CBC is sort of the first line many times in the evaluation of neoplastic conditions such as leukemia and lymphoma, and that suspicion for these diseases will often lead to a hematology consult. And in this consult, many times specimens are taken that are evaluated by hematopathologists such as myself, and we use a variety of techniques, which I will discuss briefly, such as morphologic evaluation, immunohistochemistry, flow cytometry, cytogenetic karyotyping, FISH, and molecular assays. And so I'll briefly discuss how we integrate these various tests into our practice to diagnose hematologic diseases. So in most circumstances, when abnormalities are identified on a CBC, there are common clinical conditions that result in those abnormalities. And so in those situations, typically family practitioners, general practitioners, internal medicine doctors will evaluate those disorders and be able to diagnose them without the use of a hematologist or someone like myself. And so if those studies fail to identify an etiology for the CBC abnormalities and there is a suspicion for a neoplastic disease, then a hematology consultation may take place, and that's when physicians such as myself would play a role. So in sort of the more common scenarios, here are a list of some clinical conditions and CBC abnormalities that are handled without the need for a hematology consultation. For example, a patient may present with shortness of breath or pallor and be found on the CBC to have a microcytic anemia. A family practitioner or an internist could work that up and, for example, find that the patient has a low serum iron or ferritin and make a diagnosis of iron deficiency anemia. They would then go on to try to determine why the patient would be iron deficient, but that's a common reason for a microcytic anemia. How about a macrocytic anemia, with the MCV being elevated? The patient may present in a similar manner, but the CBC would show anemia with a high MCV. And a common cause for that might be B12, vitamin B12 or folate deficiency. Again, this would be handled without the need for a hematologic consultation. How about a high red blood cell count in the setting of erythrocytosis? Well, a common cause for that is tobacco abuse, which causes an increased level of carboxyhemoglobin And the body tries to compensate for that by increasing red blood cell mass. A patient may present with cough or fever and be found on chest x-ray to have a lobar pneumonia. And the CBC might then show a leukocytosis with a neutrophilia. So again, a secondary or non-neoplastic cause for an abnormal CBC. So we're here considering some of the common secondary reasons that you might find abnormalities with the complete blood count. Patient may present with flu-like symptoms and be found to have a positive influenza test. And in that case, a CBC might show a leukocytosis with increased lymphocytes. And then a couple other examples, there may be a patient present with a high platelet count. There are many secondary causes for a high platelet count, but one that we see from time to time is the post-splenectomy setting. The patient had a splenectomy sometime in the past, and as a result carries a high platelet count related to that. On the other hand, a patient may present with a CBC and it presents with bleeding or easy bruising and is found to have a low platelet count, and a clinical diagnosis of immune thrombocytopenia may be made. So these are all some examples of some secondary etiologies for CBC abnormalities. Now, on the other hand, some of these very same presentations can result in the need for a hematologic workup or a neoplastic workup. For example, a macrocytic anemia, once a clinical workup has been performed to exclude secondary causes, I mentioned B12 folate deficiency. Other causes for a macrocytic anemia might be alcohol abuse, liver failure, malabsorption syndromes, endocrinopathies. Lots and lots of things would be considered. If all of those are ruled out and the anemia persists, the possibility of a myelodysplastic syndrome could be entertained. And at that point, a hematologist would be consulted and tissues would be procured for studies that hematopathologists take care of. Things like bone marrow evaluation, flow cytometry, karyotyping, and even certain molecular studies like a SNP array. Erythrocytosis, we mentioned that it can be secondary to something like tobacco abuse, but there's also a neoplastic condition known as polycythemia vera that can result in a sustained high red blood cell count that's uncontrolled. And again, that would involve evaluations by a hematopathologist to make that diagnosis. A thrombocytosis, elevated platelet count, while there are many times it's secondary or reactive in nature, there is a disease where it's a neoplastic disease known as essential thrombocythemia. And again, specialty tests are required to make that diagnosis. You might have a patient that presents with a leukocytosis with left-shifted granulocytes, and again, the workup failed to show a secondary cause. Then the possibility of a neoplastic condition would be entertained, and again, a variety of tests would be performed to secure that diagnosis. Okay. Circulating blast on the peripheral blood smear would definitely be a reason to have a hematologic neoplastic workup. And then finally, lymphocytosis. While there are many secondary causes for lymphocytosis, there also are neoplastic conditions, lymphoid leukemias or peripheralized lymphomas that can result in a lymphocytosis. So with this in mind, I'll just give you a little background in terms of the specialists that take care of the workups for neoplastic diseases that involve the blood or blood-forming organs. Pathologists. And pathologists are specialty MDs that basically are involved in the study of disease. And typically, most pathologists study disease by microscopic examination of biopsy tissue. That's the bread and butter work of pathologists. But now there are specialty practices within pathology, and I am one of those. I'm a hematopathologist, so I devote my practice to the study of blood, bone marrow, lymph nodes, and defining the diseases that involve those organ tissues. And again, usually those are hematologic neoplasias, leukemias, lymphomas. So as a hematopathologist, I'm a physician who has subspecialty training in hematopathology. And in a reference laboratory setting such as where I practice, integrated oncology, we mainly deal in the realm of neoplastic hematopathology. So we diagnose diseases such as leukemias, lymphomas, myelodysplasias, myeloproliferative neoplasms, and we evaluate tissues such as blood, bone marrow, lymph nodes to determine if the diseases are present. And if the disease is present, we name it so that the oncologist then knows what they need to treat. In addition to being able to name the disease, we also provide information regarding the prognosis of the disease. Is the disease going to behave in an indolent or benign manner, or is it going to be aggressive and need prompt therapy? So what are the techniques that we use in my practice? CBC is performed, abnormalities are found that can't be explained, there's a suspicion for a neoplastic disease, a biopsy of, say, bone marrow is taken, and it's sent to a laboratory such as is the one where I work, and we will then use a variety of techniques, one or more of these, to define the disease. First, we will examine the tissue via microscopy using routine histochemical or cytochemical stains. We can perform a cytogenetic karyotype, where we look at the chromosomes of the cells of interest and determine if the chromosomes have a normal karyotype or if an abnormality such as a translocation or a deletion or gains in chromosomes can be determined. We use immunohistochemistry, which is a specialty microscopic evaluation where we can determine antigens which are on the surface or within the cytoplasm of cells, and that helps us classify the cells. For example, we can determine if a lymphocyte is, say, a B lymphocyte or a T lymphocyte, or we can determine if a white blood cell is of myeloid lineage or lymphoid lineage. So we use immunohistochemical stains to help us classify cells that are the origin of the disease. Flow cytometry is a technique where we can, again, define antigens which are on the surface or within the cytoplasm or nucleus of cells. And it's a technique that allows us to rapidly define a large antigenic profile of the cells and study the disease cells to understand their origin. FISH, or fluorescence in situ hybridization, is a technique that goes beyond the karyotype in terms of defining cytogenetic abnormalities that are particular to a disease. And sometimes the diagnosis of a disease comes down to the specific cytogenetic abnormality that we might determine. And I'll give you an example of that shortly. And then finally, there are a variety of molecular assays such as polymerase chain reaction, single nucleotide polymorphism arrays, and next generation sequencing that we use from time to time to further define the cytogenetic basis of the disease. Because really all of the diseases that we study and diagnose have a genetic basis, and many times that genetic basis defines the disease. So with this background in mind, I will now present a case study to illustrate how we, as hematopathologists, make use of these techniques to arrive at a diagnosis. So this is a case of an elderly male who presented with leukocytosis that was a lymphocytosis, and the oncologist that sent us the samples wanted us to evaluate for the possibility of chronic lymphocytic leukemia. And so when the bone marrow samples were sent to us, we also received the CBC results from the oncologist practice. And you notice that the first thing that catches your attention is this markedly high white blood cell count. And the automated differential indicates that these cells are predominantly lymphocytes. And so just looking at this CBC, we would wonder about a lymphoid leukemia or maybe a peripheralized lymphoma. But without going further and looking at the smear, we would also have to wonder, could the automated analyzer possibly have misclassified some of these cells? And so we would have to think about even AML or acute myeloid leukemia as a possibility, or acute lymphoblastic leukemia. There are a variety of things that we would have to consider before we get to the point of actually performing further tests or beyond the CBC. And first thing that goes beyond the CBC in my mind is a review of the peripheral blood smear. And this is sort of the approach that we would use. We would use morphologic evaluations of bone marrow or peripheral blood, flow cytometry, cytogenetics, FISH, immunohistochemistry. This is sort of the algorithm that we use when we're studying or working up a possible lymphoma or lymphoid leukemia. And again, the first of those techniques would be the review of a peripheral blood smear. And so here I have a low power view to show this marked leukocytosis, and then a little closer inspection to show that these really do appear to be small to intermediately sized lymphocytes. And if we go a little closer, we see that these aren't blasts, so we've pretty much eliminated the possibility of an acute leukemia. We're now dealing with a more mature cell, and these look like mature lymphocytes with nice blocked chromatin. Some are relatively small, some are intermediately sized, some have prominent nucleoli. So looking at this smear, we would wonder about either chronic lymphocytic leukemia, as the oncologist proposed, or maybe a peripheralized lymphoma of some type, or maybe even a T-cell leukemia, a T-cell prolymphocytic leukemia, for example. All of these would still be possibilities just based on the morphology. So we move forward and we look at the bone marrow. And the bone marrow is markedly involved by the disease. Here we see similar lymphocytes in the bone marrow. The large cell in the center here is a megakaryocyte. It's a platelet-forming cell. There are some background bone marrow cells here, but a lot of lymphocytes. And on the histopathologic view, you can see the arrows point to clusters of these lymphocytes. And along with the lymphocytes are some background normal hematopoietic cells, the precursors to the granulocytes, the precursors to platelets, and the precursors to mature red blood cells are present. So from here, we can make use of one of the techniques I mentioned, which is immunohistochemistry. And here I show two stains. One is a stain for CD20. A CD20 is a pan-B lymphocyte marker. So if cells mark with this stain, it defines them as a B lineage. And so now I know, as I look at this collection of cells that have this brown staining of the membrane, that these are positive for the marker CD20. So these are B lymphocytes. So I'm now at least into the realm of knowing this is a B lymphocytic process. And another stain that I chose to use, we've got hundreds of these stains that we can use, and we select them based on what we are trying to define as the diagnosis. One of the possibilities here, in addition to chronic lymphocytic leukemia, is peripheralized mantle cell lymphoma. And mantle cell lymphoma is a disease which expresses cyclin D1 in the nucleus. And that's driven by the particular genetic basis for this disease, which I will show you shortly. But this is positive in the nucleus, and it pretty much defines this as mantle cell lymphoma before I go any further. But we do have some further techniques to sort of support and nail down the diagnosis. One is flow cytometry. And in flow cytometry, it's similar to the blood analyzers in that these dots represent individual cells, individual events that are being studied. But rather than just looking at light scatter features, we make use of antibodies that have fluorescent tags and determine the antigenic profile of particular cells or cell groups. And so here in the top left, we have the CD45 side scatter plot that allows us to define lymphocyte region in blue, monocyte region in green, and the granulocyte region, which are the orange colored cells. And then I can look at these cells independent of one another. For example, I can find the cells which are CD22 positive, which are B lymphocytes, and I can project those cells and only those cells onto a plot of kappa versus lambda, which are the immunoglobulin light chains. And we see that this is restricted to only kappa. So this is a B cell clone which is kappa expressing. I can furthermore isolate cells which are CD19 CD5 co-expressing, and that is a particular fingerprint for some of the B lymphoid neoplastic processes. CLL has 19,5 co-expressing cells, but so does mantle cell lymphoma. And if I look at those cells, then independent of the others, I can determine that these cells express FMC7 but are negative for CD23, and they do not express CD11C or CD103. And that is a particular immunophenotypic profile that would support a diagnosis of mantle cell lymphoma. So now I've got two pieces of information, a positive cyclin D1 immunostain and flow cytometric data, which supports my working diagnosis. We can now move to another technology. We don't need all of these in every case, but I'm showing for this case each one of them, which is fluorescent in situ hybridization. And here we look at the actual particular genes within the neoplastic cells to determine what abnormality they might have. And for mantle cell lymphoma, there is a characteristic translocation that takes place between chromosomes 11 and chromosome 14. It involves the CCND1 gene on chromosome 11 and the immunoglobulin heavy chain gene, which is on chromosome 14. And here we see a normal cell, and the green dots represent the CCND1 gene on the 11 chromosome, and you have two of those. And the red dots represent the IGH locus on chromosome 14. You have two of those. A normal cell would have two of each. But for the abnormal cell, we see that what's happened is you still have one persisting red and one persisting green, but now there's been a translocation where the red and green were brought together, and there's a new gene formed by this fusion, and it's the yellow signal. Red and green make yellow, right? Remember from your primary school color exercises. But that yellow signal is the abnormal gene signal, and that is the gene that drives this disease, that abnormality. And it also is the gene that results in that overexpression of cyclin D1, which you saw on the immunohistochemical stain. Finally, here's the karyotype for this disease. And when we talk about a three-line karyotype, normally a karyotype is 46XY, and that's all you see. When we talk about a complex abnormal karyotype, this portends a worsened prognosis for this particular disease, and you can see all the abnormalities that are highlighted. So the final diagnosis for this case is leukemic mantle cell lymphoma. Mantle cell lymphoma is a particularly aggressive type of B-cell lymphoma, and it must be distinguished from chronic lymphocytic leukemia because many forms of chronic lymphocytic leukemia, CLL, are indolent. And many times patients will go 5, even 10 years without needing therapy for CLL. But mantle cell lymphoma needs quick attention, especially when it presents at such a high stage as this with leukemic involvement. And it can present in a leukemic form, and that's particularly bad. And it, again, must be distinguished from chronic lymphocytic leukemia. And as you saw, we have a variety of techniques to make this distinction and get a solid diagnosis. Morphologic evaluation, immunohistochemistry, flow cytometry, FISH studies, cytogenetic karyotyping, all can help. So in summary, the CBC identifies abnormalities of the blood, many of which are secondary in nature, and workups by the family practitioners, the internal medicine folks will define the etiology. They can correct that, and everything's fine. But when some of these abnormalities persist and remain unexplained, patients will be referred to hematologists. Hematologists will then evaluate the patients for the possibility of a neoplastic hematologic disorder, such as leukemia, lymphoma, dysplasias, proliferative diseases. And in those evaluations, they many times procure tissues that they send to laboratories such as the one where I work, and we use those techniques that I just discussed to arrive at a final diagnosis and offer some information about the prognosis of the disease.